So one of the things that we noticed in the many meetings that we had across Ontario, so we've so far been to 5 communities and we'll be getting to Ottawa this Wednesday, is that many teams had developed an initial leadership infrastructure for their team, and then through both the self-assessment process and now as they work on the full application, they're learning what's working well and what could be improved. So what we did on the RISE side was we identified individuals who we had encountered through our travels who would be able to speak to 4 of the issues that we heard people mentioning. So we're going to have 2 individuals speaking to how their teams have developed their leadership infrastructure. So that's Lori Marshall and Matt Meyer. I'll introduce them shortly. We have one person, Heather Bullock, who's a colleague from RISE, talking about how to balance standardization and local contextualization and the importance of being aware of and considering how best to leverage relevant regional and provincial assets. Then we have Paul Johnson from the City of Hamilton talking about how teams can begin incorporating planning for broader human services within a full and coordinated continuum of care. And then finally, assuming that his mic gets sorted out, and it has, I can now see his audio is connected, we'll have Kyle Fitzgerald talking about how partners who are helping out multiple teams can balance all of the meetings that people are rushing to organize in these coming weeks with all of the already existing demands on their time. So we're grateful for those 5 panelists for joining us today. And this is very much in keeping with what we're hoping to accomplish with RISE. It's not that we have a single answer to these challenges, it's that we're seeing lots of innovation happening across Ontario, and we want to share those innovations with you in case they're helpful in your own work. So if I move on to the next slide, this is just emphasizing that point that we hope that hearing from people that are part of the OHT community of practice will get you thinking about what's working well and what can be improved within your own leadership infrastructure. As we go through the slides, if you have observations about lessons learned from your work with your leadership infrastructure, or if you have any questions for any of the panelists, please just add it to the chat box or the Q&A. Steve can confirm for me which is the preferred. Steve, can you come back on again and just remind me, do you prefer the Q&A box?
The chat box. The Q&A is a bit harder to moderate, so if we do the, if you use the chat box instead, that would be great. There's a number of people that are commenting in there already, so it'll be...
Super. Excellent. And then my colleague, Carrie, also from RISE, Carrie Waddell, is going to be keeping track of those points coming in through the chat box, and she might, when we get to the discussion and Q&A, might point some of those queries to the panelists that have joined us today. So some of you, if you were able to attend any of the 5 regional sessions that we've had to date, you'll know that we put up a slide to talk about a leadership infrastructure that emerged from work that had been done in the Toronto Central LIN, and we have a RISE brief on this if you want to read more about it. I've made some minor tweaks to the slide just to reflect, I guess, increased specificity about how some groups are setting them up. But this is just to jump into the conversation shortly with Lori and Matt to hear how they have set theirs up in detail. But we're certainly seeing many groups set up an executive leadership group, often comprising CEOs and executive directors of partner organizations. Very often they have here 2 groups. One is the very large partnership council. This is often 20, 25, 30 individuals representing that same number of organizations. And then they often have an executive sponsor group, which is a smaller group drawn from the partnership council that then allows the group to make relatively rapid fire decisions as issues emerge while bringing the big substantive or strategic issues back to the full partnership council. We've heard from many teams across Ontario that they also then have an integrated operational management group, often comprising folks like the vice presidents of operations or directors of programs, and often communications folks sit around this table as well, because it's so important to be hearing from local community members about what is important to them, as well as from local providers, but also to be able to communicate out to the broader community about the work that is being done. Some people have called this group an Oversight and Coordination Secretariat, and then often there's a subgroup of that which is part of a project management office. So for some people, that might be one half-time person. For others, it might be two people if you've been able to find the resources to staff this. The third thing that we see teams doing is setting up what you could call working groups. Some call them secretariats. Very often, we're hearing that teams are setting these up, one for every year one priority population. So if you are a team that has, let's say, picked 3 year one priority populations, you might have 3 distinct working groups that are doing work specific to that priority population, but then hopefully coming together as well to share lessons learned. So there's a common approach where appropriate across all the priority populations. We're also hearing groups about teams that are setting up working groups focused on high priority building blocks where there's really a need for dedicated work in the short run. So as you've heard us say at regional sessions, teams will, going forward, need to be putting in place all 8 building blocks for an Ontario Health team. But some of the examples of the building blocks that are getting more short-term attention are building blocks like digital health, which is building block 5, and leadership, accountability, and governance, which is building block 6. And then some teams as well, if they have the bandwidth for really thinking through the types of input they'd like to provide to the ministry about the future direction of home care, they have set up a dedicated group to think through that. But many, many other teams are focused more on what specifically do they need to think about home care for the year one priority populations, and not necessarily standing way back and say what should be the future of home care, which is more what the appendix is focused on. So those are just some introductory comments about some patterns that we're seeing across the province, but there's a lot of variability, and we think it will be even more helpful to you to hear from 2 teams, so I'll come to them shortly. The other things that we're seeing is very often teams have explicit terms of reference for each group, just to be so everybody's clear about their marching orders and so on. We have talked about in the regional sessions, if you've been able to attend one of them, about the helpfulness of having some guiding principles for working groups focused on year one priority populations. You can see a list of 8 candidate principles that you can add to, delete, adapt, and so on as appropriate in the summary sheet that accompanies RISE Brief 6, 8, and 9. And while it's more of a forward-looking step towards collaborative governance that teams will eventually move to over time, some are already starting to put pen to paper to have a light touch written agreement that addresses things like how are decisions going to be made, conflict resolved, performance managed, information shared, and resource allocation. But not all of those details need to be sorted out for the application deadline. That is work that can be discussed now, but ultimately finalized well into the future. So with that introduction, I'm going to turn it over first to Laurie Marshall, who's the CEO of the Chatham-Kent Alliance. And then after we hear briefly from her, we'll hear also from Matt Meyer, who's the Population Health Lead for the London Health Sciences Centre. Again, I'm talking in generalities, and we think it might be much more helpful to you to hear from 2 individuals' direct experiences with setting up and adjusting a leadership infrastructure. So Laurie, can I turn it over to you?
Terrific. Just checking that you can hear me first.
Yep, absolutely.
Okay, perfect. So thanks for this opportunity, and what I'll do is just sort of give an overview of how our team came together, how we're working together between now and October 9th, and some of the things that we maybe found helpful and some of the things that we're thinking about for the future. So the Chatham-Kent Ontario Health Team, we have 14 organizations that we call our Phase 1 partners, and it ranges from the Chatham-Kent Health Alliance with our 2 hospitals. We have the 3 family health teams and the community health center. The great thing about the primary care piece for us is that there are actually only 4 unattached primary care providers in the Chatham-Kent region. And so we really have the majority of primary care engaged in going forward. We have our hospice, we have March of Dimes and Alzheimer's, Canadian Mental Health Association, Behavioral Supports Ontario, We have the municipality who have signed on, and that's significant for us for a couple of reasons. It brings long-term care into the discussion. It also has the EMS with the visiting paramedic program that's funded by the LIN, so that allows us to have those conversations, and also public health. And I would say that that's been really helpful for us in that we are a rural community. We aren't sitting with an academic health sciences center to allow support and give support to where we're headed. And so we've been able to, I'd say, really rely a lot on secondments from different organizations. So whether it's the epidemiologists from public health, whether it's some project management from the LIN, we really are relying a lot on partners to set things up to go forward. So, and the other piece is that we have Transform Shared Services, which is responsible for the, as a membership organization, the digital side of 5 member hospitals, as well as our procurement. And so they've been able to come to the table as that particular partner. A couple of things that I think are significant in how we've moved ahead. So we do have a steering committee that's now responsible for the submission by October the 9th. It is representative of the CEOs and executive directors of those various organizations. I've also added a primary care provider as a co-chair and 2 patient advisors to that particular steering committee. And then what we've done is from the steering committee, we've established 6 different work streams that are reporting into the steering committee, and each one of those work streams has 2 of the members from the steering committee who act as co-chairs, particularly right now in terms of vacation periods and those sorts of things, just to keep everything moving. And one of those work streams, I would say, it is the population performance and quality work stream. They are also what we consider to be our secretariat. So that particular work stream is not only sort of working on those pieces of the overall submission, they are also providing the project management support, the data, the coordination for each of the other work streams. And there is a small set of that secretariat then that are responsible for being sort of the writing team at the end of the day. So that while each particular work stream is going to be working through their part of the document, what we want to ensure is when it all comes together that it actually flows, that it tells a story from beginning to end, and that is part of their responsibility. Our steering committee meets weekly. We have a teleconference for an hour every week. And then on occasion, when something's significant, we do then come together. I mentioned the patient advisors at the steering committee. We've also been very successful in getting at least 2 to 3 patient advisors who are sitting on each of the other work streams. And the other work streams other than the population health one are integrated care design, and they're responsible for also working through the whole clinician engagement and how we're setting that up. We have a home and community care work stream, digital and virtual access to care, a diversity and equity work stream, and then the governance and leadership piece. The last piece I want to mention is about maybe around our decision making and going forward. So one of the things we've determined, given that while the document says that it needs to be signed off by the board chair, I'd say the majority of our organizations, that means that the board must have approved it before the board chair can sign off. And we all have various dates and different kinds of processes through the course of September. Each of us are taking it as our responsibility to work that information through. But what we have also identified is that we're going to have one large session the first week of October. And it remains to be seen how this is going to work for us. But the plan is that because we've all been working together, keeping our boards up to speed as we go through the process, that they will be prepared to come to an all-board meeting the first week of October and have a brief presentation, and then we'll have breakouts for the 14 boards to essentially go away and consider and approve some form of a resolution. And then that still gives us some time in the event that somebody couldn't get quorum there, or that there's an issue that comes up that we hadn't anticipated through our working together over the course of this, that would then allow us to move forward to submission. And the last piece, maybe I'll just mention, is reiterating the importance of that communication strategy. I mentioned we have 14 organizations that are phase 1 partners. We also have another 30 or so organizations that either weren't part of or we don't anticipate to be part of the year one population. So, for example, our year one population at this stage is looking at older adults with chronic disease and some level of frailty, and that we may have some children's organizations that are involved. And so, they want to still be in the tent, but they aren't necessarily going to be part of the year one. So we have had some full engagement sessions with 80 to 100 people in the room at that time, just to keep everybody up to speed. And then we now do have some seconded communications resources as well to really focusing on how do we keep this going, how do we brand the CKOHT and take it to the next further steps. Maybe I'll end my comments there and look forward to hearing from others.
Fantastic, Lori. Thank you very, very much. You covered even more than we'd had the chance to hear from you about at the session in London. One of the many reasons why your group caught our attention was there were 5 CEOs or executive directors all sitting there with you walking the talk of what the future looks like. So all the different kind of core, 5 of the core partners of the 14 sitting there, but you've also now helped us with understanding secondments, work streams, and how you're moving towards sign-off, especially with this cross-board event. So this was hugely helpful. Thank you very much for running through that so efficiently. Matt, can I turn it over to you to hear about a neighboring team, and perhaps in your case with so many things, because you're connected to an academic health science center, you might be fending people off. So can you just talk about how you've been approaching this work?
Yeah, absolutely. Thank you. Can you guys hear me okay?
Yep, absolutely.
Perfect. So it's great to hear the discussion or description from Laura. That's excellent. And I think we share a lot of similarities in the approach that we've taken. So right from day one, your CEO here at London Health Sciences Center, Dr. Paul Woods, has been involved in accountable care and really has been sort of preaching to all of us the idea of a healthy ecosystem and how we really need to work well with and engage all of our partners across the region and be much more holistic in the way that we consider care. And so I just mentioned that because I think from the beginning of how we've created our approach and the approach that we've taken, we've very much been trying to be open. So I would say we're not actually trying to fend anyone off. We've very, very much been trying to engage as many partners as possible in the process and to be thinking about how we can establish a shared partnership and a collaborative structure working forward with all of those partners. And so the way that we've essentially begun is that we actually didn't select a priority population in our readiness assessment. Instead, the approach that we took was we worked with all of our partners to iron out what, kind of an agreed upon process that we would use going forward, thinking about not only selecting a year one population and how we would organize to support their care needs, but to be thinking beyond that in terms of how would we use this process to select the population for year 2 and 3 and 4 and beyond. And so the way that we did that, we've got wonderful leadership from a number of organizations across the community. The ones that have been signing partners for us, we've made a distinction at this point, at least based on the readiness assessment, between signing partners and future partners. So the signing partners were the ones that were willing to commit and actually put pen to paper and say that they're going to join. And so we have signing partners representing primary care, home care, community support services. We have patients, families, and caregivers engaged, emergency health services, and then the hospitals, of course. And the hospitals in our region, being London Health Sciences Center, Middlesex Hospital Alliance, and St. Joseph's Healthcare in London. And so we basically had had those partners kind of agree to the process that we were going to use. We came together in terms of putting that readiness assessment. And once we heard the news that we were selected for full application, we then went forward in creating what we've called a coordinating council. And we've been very careful to let people know that the coordinating council is not the ultimate governance structure, but what we're looking for are those senior leaders from those organizations to help us plan for what that governance structure ultimately will look like and to be considering everything that we need. So the way that we've gone about creating that, we have 2 representatives from each of those sectors that I mentioned, and they're coming together. Our first meeting actually will be this Thursday for the coordinating council, but we've been giving them updates throughout. We have that co-chaired by a patient advisor and a health services provider. And so, so that council is going to, in the interim, help us move us towards that full application. But as I said, really put focus on the processes we're going to use to get the work done in year 1. Under that coordinating council, we've created what we're calling a secretariat. And so the secretariat is where we've engaged people in a number of different areas. So Nancy Dolcontio is our director of that. We have a project manager, Volbrecht, who's been helping us as well. And that group has been meeting to talk about how do we pull together and make sure there's good communication across all of our sort of work streams, if you will. So there's that coordinating council, which we're tasking with a lot of the administrative pieces and that, thinking towards what governance will look like. The Secretariat is supporting all of that work. And we have a population health group that's been focused as well in helping us to select our year one priority population and again, create that process going forward. We've got a digital health group and then we have a home community care work stream as well. And so the Secretariat is helping to make sure there's consistency across all of those groups, and then we'll be sharing that information to our coordinating council. And I would say maybe just the last thing I'll sort of talk about in terms of the process that we've been using and how we've been laying out. As I said, we decided that it was most prudent for us not to select a priority population in our readiness assessment, but to create the process. And out of that process, we've come up with this concept of a population health coalition. And so what that is we've created a group of individuals who have expertise in population health, but that have no affiliation to any of our care providers. And so the idea is that group, again, benefiting from the fact that we have Western here and we have lots of academic minds in the region, that group has come together to help to guide some thinking about what should a population approach look like? What does population health management mean? How do we identify that population? How do we create strategies in sort of a fair and open way? But also how do we think about things like equity considerations? And so that group is working through what we've done is we've allowed stakeholders to make suggestions for populations. The Population Health Coalition works through that material and will come back now to the Coordinating Council with recommendations. And so we always have that kind of arm's length group that's giving us some information in terms of where we think we should go. Yeah, maybe I'll stop there, but again, happy to answer any questions as we proceed.
Super. One thing, Matt, just out of curiosity, Laurie gave us a sense of the size of some of these different groups. Can you give us a sense about just roughly how many folks sit around the Coordinating Council table, the Secretariat table, and the Population Health Coalition table?
Yeah, I don't have the exact numbers in front of me, but we did hold Jillian Kernahan, actually out of St. Joseph, helped to host a session in June when we were pulling together our readiness, earlier when we were pulling our readiness assessment together. I think we had 82 community organizations come to the table at that point to just suggest interest. And I don't have the exact number, but I think in terms of representatives for those sectors that will be sitting on the Coordinating Council, we're in the ballpark of sort of 20 to 30.
Gotcha.
The Population Health Coalition at this point has 8 members, but we're looking to expand that and invite people in.
Super. Excellent. Sorry to put you on the spot with that one. I was just looking for order of magnitude, so that was very, very helpful. Thank you very much, Matt. So let's move on to now a second topic. So this one is about balancing standardization and contextualization. So many teams have picked a year one priority population, and Matt just described an interesting process for zeroing in on those. The more that we ask folks what they pick, the more we find that they're often dealing with similar populations. So we've just given one example here that we're hoping to work through to get you thinking about that issue of balancing standardization and contextualization, and that's the case of adults with mental health and substance use problems. So while many teams are co-designing local approaches to population health management, we think that over time, one of the things that the OHT community of practice can do that will really help teams is get the groups that have that similar focus talking about where would it be appropriate to standardize approaches. So in many areas in the mental health and substance use domain, one would hope to see a fair amount of standardization, but also where would it be appropriate to have that local contextualization. And then the second thing is that not everything needs to be done locally, and we have a lot of activity happening at the regional and the provincial level that teams will be able to draw on as part of their implementation plan for reaching those year one priority populations. So with that quick introduction, I'm just going to turn it over to a fellow RISE person, Heather Bullock, just to talk through that particular example of teams that are focusing on adults with mental health and substance use problems, just to give you some ideas about some of the things you might want to be thinking through. So Heather, can I turn it over to you?
Thanks, John. And hello, everybody. So you may be wondering why I'm talking about this, and it's because I have spent most of my career in mental health and addiction in Ontario, various different organizations, and most recently studying mental health policy implementation through a PhD. So while I'll be participating in RISE in a way more general health capacity, I do have a bit of an understanding of what's been happening in the province as it pertains to mental health and addictions, and how I think we can start to think through some of these divisions about what needs to be local, what should be regional, provincial, and also how we're leveraging some of the assets that exist in the system. So using the population health management approach, you know that you need to design a suite of in-reach and outreach services as well as care pathways, beginning with your year one populations. And as John mentioned, many of you have identified mental health and addictions, adult, transitional age youth, some I've even heard for children and youth. So while you're doing this, it's important to be aware of and leverage, where it's appropriate, services and supports that are available regionally and provincially. And this is really about managing the tension about what needs to be available and funded locally versus what needs to be available and funded regionally or provincially, just from a cost management perspective and also from an infrastructure perspective. So I thought I would just touch on some of the work that I have previously been involved with that are newer initiatives in mental health and addictions and people may not be aware of. And so recently the province has been undertaking a massive effort to bring structured psychotherapy to people with both depression and or anxiety across the province. And currently we have two supports that are available now provincially. One is called Bounce Back, which is online supports with telephone coaching, and Big White Wall, which is moderated peer support. So it's an electronic asset. And these are available currently across the province to anyone who might need them. They've also been trialing some in-person structured psychotherapy, focused mainly right now on cognitive behavioral therapy. That's currently available in 4 regions in the province, close to where there are the specialty hospitals that focus on mental health and addiction. But there is hope that over the next fiscal year that will be scaled out across the province. So there might be even more resources and assets for you to leverage with your Ontario Health team. Also, I wanted to mention for transitional aged youth, there has been another huge thrust around developing youth hubs. I think there's 10 currently across the province, and these focus on transitional aged youth. So just trying to do a little bit of context and really understand what some of those initiatives are, what's coming down the pipeline potentially, and how you might be able to plug in. There are always going to be some assets that make more sense to be delivered provincially or regionally, just in terms of economies of scale or the types of expertise that are required to deliver them. I'm thinking of things like in mental health, forensic services, or something that requires technology like RTMS for depression. So, when you're building those care pathways, at some point you're going to have to transition to point to a transition to some of these specialty resources, and they're just going to be things that you're going to have to think outside of your team for. Other things that I think would be helpful in terms of developing the thinking for the year one priority populations is thinking about what's available in terms of coordinated access initiatives and whether you might be able to tap into a coordinated access initiative that exists there separately in mental health. And these might be assets that you could leverage as a team, but they might serve more than one team. Way to think about what's available in your region and what you can tap into. And as John mentioned, we're going to be doing over the next couple of weeks, doing our best to connect teams with one another that have similar priority populations for year one, so that you can share and learn together. And hopefully that'll make everything more efficient. And also you can leverage the thinking and understanding that other people have done already to date in terms of their planning. So I think I'll stop there. John, is there anything else from your perspective that you wanted me to touch on?
No, that was great. And just Heather mentioned population health management, and specifically she used the language of in-reach and outreach services along with care pathways. Next week in the lunchtime webinar on Tuesday, we're going to have Rob Reed talking in more detail about his practical experiences at Puget Sound Health Cooperative, now Kaiser Permanente in the U.S. with population health management, and specifically some of these areas like in-reach and outreach services that have not been yet widely taken up on Ontario. We have more experience with care pathways, but less with in-reach and outreach. So if you want to know more about that, please join us next Tuesday. And the other point, as Heather mentioned, is that we'd strongly encourage you to share, if you're willing to, with us, your priority populations. We can then quickly connect teams with one another that share priority populations. The best way to do that would be through the OHT community of practice. You can just log into the online platform, post them, then we'll do a quick analysis and identify teams that are working on a similar population, get that out to you so that you can share resources and where appropriate, connect up. And you could also send us an email at rise@mcmaster.ca. So we would not have access to that information unless you share it, and we're happy to quickly turn it around and make connections. So thank you very much, Heather. That was very helpful. We're just going to now move on to incorporating broader human services. So Lori alluded to this in her comments. She talked about how they have their local municipal government as a partner. And we recognize that while in these early days, many teams are focused on finding new ways to work together among their fellow health system partners, we're seeing some teams, including municipal governments in their partnership planning, to bring an even broader array of assets to the table. I've just listed three, and Lori has alluded to at least the first one in her comments, but that would allow you then to access EMS and long-term care homes that are when they're overseen by municipal governments. But municipal governments also have their hand in a number of other pies that are really helpful for population health management. So for outreach services, which Rob will talk about more next week, if you haven't had contact in the health system with someone for a long time, but they have in the past been a heavy user of an emergency room or been admitted frequently to hospital, one of the things you want to do is try to bring them back into the system. And in the early days, it may be housing and social services that are actually more needed before they can start to take advantage of the health care services. And then another advantage of having municipal governments at the table is they often have a unique set of levers to influence, using population-based strategies, the health of entire communities. And I've just given an example in brackets here. But today we have the good fortune to have Paul Johnson here, who's the General Manager of Healthy and Safe Communities for the City of Hamilton, who is a very active partner of the Hamilton Health Team. So I'm going to turn it over to Paul in the hopes that he can give us a flavor for, in his local community, how municipal government is coming to the table to really help to take the local team to significant success. So over to you, Paul.
Well, thanks very much, John, and welcome to everybody on the webinar. Certainly in the city of Hamilton, and I know in other municipalities this is the case, we've had a history, in our case over the last 9 years or so, of working alongside a variety of institutional players to look at things across sectors. So the involvement of hospitals in terms of looking at educational and municipal work, and municipalities involved in some educational and health work, has a bit of a history in Hamilton, and that sort of helped us be really embedded early on. And in fact, in Hamilton, in terms of the catalyst to bring this group together, it really was our two hospital systems, St. Joseph's Healthcare Hamilton and Hamilton Health Sciences, and the municipality, that then worked through a number of connections we had to bring the groups together in these early stages. And now we're needing fairly large rooms to meet, which is fantastic. But at the core of it was some of these anchor institutions working together. And from the City of Hamilton's perspective, the department that I have the pleasure to lead each day made a lot of sense as the major connector to the municipality. Within our department, our children's services, social assistance and employment, housing, long-term care, fire, paramedics, recreation, and public health. And so as a department, we play a critical role in terms of the services that are provided. But then through my contact with our senior leadership team, we bring some other pieces to the table. And certainly transit, I think, is going to be a huge issue that communities will have to deal with as we have larger and larger numbers of our communities potentially without the ability to drive as they age and live longer. Transit is going to be a very important piece of the puzzle. And then you have the planning and the building department. We've worked through a number of interesting projects with healthcare that have, challenged our building department to think a little bit differently in the way they view some of the construction and the readaptive use of some of our buildings. And we've got there by and large, but sometimes it's a bit of a rocky ride and quite frankly takes longer than everybody hoped. So the goal here would be to educate our building department, our planning department around how things are changing so that we can better support the work. And then, of course, public works, the things that happen each and every day to keep the community moving along, those are important connections. So I think that it made a lot of sense for this department that I play a role in to be at the table, and certainly built on a history of involvement with anchor institutions. So we have been at the leadership table. We're part of the executive sponsor group in Hamilton alongside primary care and our hospital systems. We've added some other pieces where we host the website for our Ontario Health team through the municipal website, and we also host the staff that are working through our project management office within a city facility. And a couple of things: A, we had facilities available, but B, a little more of a neutral feel to it. And so people were quite excited that we could be part of we could offer up some space and have our staff working in a facility that didn't seem to be as tied to one healthcare institution or another. And I think in the early stages, that's all the dance we're doing with the multiple agencies that are part of Ontario Health teams is we do trust each other and we do want to work together, but we're also charting new territories. And so it's helpful to have a bit of that neutrality. I think what really has been a driver for us around the municipal involvement in the broader human services world is that, these are the kinds of services that actually have a role in what makes people healthy. Those conditions of daily living are actually delivered more so by municipalities and their partner-funded organizations than anywhere else. And the other interesting piece about municipalities, of course, is their role as a service system manager. So when you think about childcare or housing, employment, and social assistance, there are these significant roles that are provided through legislation in terms of service system management. And what that does is it allows there to be a bit of coordination already happening on the ground rather than working with multitudes of local nonprofit organizations or for-profit organizations. There can be some of that coordinated work through the municipality that's already required to do that as well. And then there's some of the broader planning. I know in Hamilton, as in other places, there are municipal age-friendly plans, for instance. And so how can we leverage some of the planning work that's already occurring? And, funding is always an issue. And municipalities and through their partner groups have access to other funding. And that's not for a second to suggest that we're finding a way to fund healthcare through a property tax base. Our councillors and our mayor would fire me on the spot if I was suggesting that. But as you know, working with the partners and working with the different funding streams that come to the broader human services world, I think there are opportunities to bring new resources to the table that can help us meet some common goals. So I'd leave you with just a few of the questions that we're working through here in Hamilton, which do draw in very significant ways the broader human services world, and in particular the role of municipalities. And one of the things we're talking about is how do we build housing as we move forward as a community, and we're building all sorts of different types of housing. How do we do that in a way that provides opportunities and access or through design, the right kinds of service or technology or other considerations that can be included that will help our health sector partners in terms of delivering that care in the community. Obviously, how we locate services and support place-based approaches to services can be really useful as we look at transitioning people back into community. And I think the big conversation we're having in Hamilton is how will the municipality play its position to support the broader health work that's going on. And perhaps that means us getting out of a few things and allowing others to do it, knowing that better supports are provided by other players within this. And really that leads us to how do we reimagine human services moving forward. It has really been two ships moving forward, health and then human services, and lots of opportunities on a point-by-point basis or a project-by-project basis for collaboration and working together. But I think we're trying to work through, and our Ontario Health team approaches will help us do this, is what would reimagining that work to be far more integrated from its design look like, as opposed to an endless series of agreements and partnerships and collaborations on a place-by-place or point-by-point basis, which are quite frankly hard to manage and not perhaps the best use of resources. And there have been some great conversations about opening our eyes to the things that each other do that we didn't know about, and it can be very small. I remember there was a family physician at one of our meetings who lamented a bit that she had a patient that every summer, like clockwork, would end up in an emergency department 4 or 5 times just because of the heat in the apartment and the COPD issues that person was dealing with. And they said, "Boy, it'd be just great if I could buy an air conditioner." To which I said, "Well, we actually have a municipal program that does that for a number of families each and every year." And of course, the light bulb moment goes off, and it's everything from that to the way we could look at our paramedics delivering service to the 70,000 doors that they enter on a yearly basis, and all of those pieces in between. And, I mentioned in one of our meetings, between our 430 long-term care beds, our 1,100 residential care facilities, our 600 emergency shelter beds, and our 14,400 units of social housing, we are an integral part of the healthcare system, and no one was disputing that. And I think we have the role as a municipality to say, how can we do our job better? But on the other hand, how can we use these assets more wisely? And that's been really an important conversation in many of our tables, and looking at many of the subpopulations and our year one populations that we're trying to look at. There's been many of these conversations that have pushed forward. So I think that, there's lots that we can offer as a municipality in the broader human services world, but also a lot that we're going to be learning so that we can co-create this as we move forward.
Fantastic, Paul. Thank you very, very much. You've taken my 3 anemic bullets and turned them into about 5 superb slides with all of these assets that municipal government can bring to the table. So I'm going to go back to the recording and make sure I capture all of that wealth of the wealth of ideas that you provided. So thank you very, very much for sharing those thoughts. Can we move on now to folks that are in the situation of serving the same population that multiple teams are serving? We've heard at many of the regional sessions how difficult this can be, but also some of the innovations that are happening that make this doable and can really add value across the province. So when we've had side conversations at many regional sessions, many home care providers have been among those approaching us saying, boy, we're really struggling with this issue of we're involved in about 5, 6 different teams, sometimes many more, and every team is organizing many, many, many different meetings, and we want to field people, and we're afraid of missing stuff. We feel we should be there, but at the same time, we're trying to keep our services going, and our executives can't be away from all of those kind of frontline responsibilities all the time. I guess, one of the things that's come up in the conversations with that group, the health service provider community, is maybe you don't need to be there for all of them. And right now, the absolutely essential piece that intersects with their world is co-designing population health management approaches for year one priority populations. So if you need to make tough choices about which meetings to be at, that would probably be the place where your very strategic involvement would go the farthest, the fastest. The other type of conversation that we've had are with community-based organizations that don't necessarily face this trade-off in terms of having their executives in other places and then having difficulty with frontline service provision. But what we're hearing from them is very innovative approaches for how to work out how best to support their staff and volunteers so that they're taking helpful messages out to the community, and then vice versa, bringing intelligence back to others so that folks can learn from one another. So with that, I'm going to turn it over to Kyle Fitzgerald, who is the Manager of Government Relations and Public Policy at the Alzheimer's Society of Ontario. He was one of the examples of folks from a community organization that really impressed us with how they're supporting the participation of people in local communities in these team planning exercises. So Kyle, can I turn it over to you? Kyle, looks like his mic has gone. Kaylin or Carrie, do you have, Steve or Carrie, do you have an update for us about what's happening with Kyle's mic?
I spoke with him.
Sorry, go ahead, Carrie. Carrie, are you still there? Okay, while we see if we can sort out Kyle, let me just tell you briefly one of the things that struck us. So the Alzheimer's Society, as many of you know, has, and I'm not sure I'm going to get the language right, but let me call them local chapters. And what Kyle and his colleagues at the kind of head office are doing is one day each week, I have Tuesday in my head, it could be Wednesday, they are convening all of these individuals from across the province that are participating in these local team-led processes. And it's an opportunity both to share messages that individuals in the local communities might want to share with their respective teams, but it's also an opportunity for those folks that are participating in these processes in local communities to share back to the Alzheimer's Society some of what's coming out of these local conversations. So it seemed like an incredibly efficient way to help folks in local chapters really add value to local planning processes, and right now focused on getting those applications completed. And then the flip side is that then the Alzheimer's Society is learning from all of these local planning processes, and then that's giving them ideas for the next round of how they can support their local chapter leads. So that's just one example that Kyle was able to share with us at a regional planning session that is making it very, very efficient for their local chapter leads to really add value in local processes. So if we can't bring Kyle back on, and maybe we can keep problem solving with that, why don't we move on to the question and answer period. Just before I do that, a reminder that these topics that we've spoken about today, we often have RISE briefs on them, which can complement the insights that you've heard from our panelists. So we have a RISE brief specifically on leadership infrastructure and work plans. And then while we heard from folks like Matt that they're not trying to nail down all the specifics of governance now, but they're embarking on a process that will get them to collaborative governance. That is the focus of another RISE brief. We heard from Lori the tremendous success that they've had in Chatham-Kent in getting primary care provider participation locally. And for those who might not be in the same position as Lori, we have a RISE brief about that. And then Heather has alluded to concepts like in-reach and outreach services as part of population health management. And I've alluded to some guiding principles for working groups, and all of that is captured or addressed in RISE Brief 6. But you're also going to have an opportunity to hear from someone with now almost a decade of experience in population health management in the U.S., Rob Breed, who is back in Canada and a co-lead of RISE. So,
John, can you hear me?
Yes, go ahead, Kyle. I'll go back to your slide, so please jump in.
Okay, so I can't hear through my phone and I can't speak through my computer, but between the two of them, we've got it sorted.
All right.
Working just fine. So I actually wasn't listening. We were trying to work it out when you were speaking there, so I apologize if I'm repeating myself. But thanks, everyone, for joining, and thanks, John, for the opportunity to present. So by way of background, the Alzheimer's Society is an organization with a province-wide mandate that has 29 local societies province-wide, as well as a central coordinating body, which is us, the Alzheimer's Society of Ontario. Part of the structure of our organization is that we offer a core service standard province-wide, but also have local societies have the flexibility to tailor some of their non-core services to meet local demands. So how we've been sort of handling this approach is from the beginning, we've recognized that because dementia touches upon every corner of the province, we've had a very, we've been clear from the beginning that we want to be at every single table, and which is great because it opens up new partnerships, but as several people have pointed out, it also places a tremendous amount of strain on our staff at our local societies. And we've heard from some of them who are involved in 3, 4, or more Ontario Health Team applications that they're meeting as much as once or twice a day between the different health teams and the different tables at each of those teams. So that's one of the challenges. The other challenge that some groups are facing comes in terms of a financial strain. So as great as the resources are that are being offered, there's still many teams that are being asked to support financially external consultants. And for smaller nonprofits, smaller community groups, that can be a considerable challenge, especially when that money has to come from fundraised dollars. So how we've been addressing these challenges is really trying to leverage our province-wide reach to provide information sharing and to scale up and spread what's working province-wide. So we have weekly touch points within the Alzheimer's Society where all of our local chapters are able to share what's going on locally, ask questions, gather information, which we then take back centrally, summarize that into helpful documents, and share that around within the Federation, as we call it. So that's really trying to offload some of the responsibility from our local societies so that we can manage that provincially. And we're hearing that quite a few other province-wide agencies are taking a similar approach, and we also coordinate that at our level as well, so seeing what we can learn from other province-wide bodies. Now, this is obviously an approach that doesn't work for smaller providers that don't have the benefit of a province-wide coordinating body, but what we can suggest and what we have been hearing about is providers connecting with other providers in a completely different part of Ontario that are in a similar boat, as to being able to share what they're learning, to share their feedback. So part of the challenge, as I mentioned before, is that because we have 29 societies and because there are now we're hearing well over 50 Ontario health teams, it means that most, if not all, of our local societies are part of at least 2 Ontario health teams, which sort of doubles the time commitment that they face. So what some of them are doing, which I find quite innovative, is essentially working together to split the workload. So instead of one local chapter being at every single table, they're working together to sort of divvy up the workload. So this is a way that we haven't had to trade frontline service, trade long-term plan in order to be at every table. So I'm just looking at the clock, and I want to leave time for questions. So I'll leave it at that. But thanks, John, for the opportunity.
Thank you very, very much, Kyle. I'm glad we sorted out the audio problem. So I've already covered the RISE brief, so let's open it for people's observations, questions. Carrie, have you had any come in through the Q&A box?
I have had a few, so I can read those out to the different panelists that they're addressed to. And then if anybody else has any others they'd like to add, please feel free to send them in the chat box and I can relay them to the group.
And do you want to, Carrie, just go through them quickly and then we'll just quickly turn it over to the panelists. It'll just give them a bit of prep time.
Yep. So the first question is from Matt and Lori. And the question is, what types of roles exist within the secretariats and how have these been filled?
And do you want to keep going, Carrie? Just go through the list if you have some for the other panelists.
Sure. So a quick question for Heather is, where are the 4 cognitive behavior treatment services located regionally? And a question for Paul is, we have our district social service board, our OHT. Do you think there are any greater challenges with municipalities joining a shared governance model? Do you think that there are greater challenges with municipalities joining a shared governance model than any other organization?
Very helpful. Super. So, Lori, can we start with you with the question that was directed at you, and then we'll turn it over to Matt?
Sure, be happy to. So in terms of the Secretariat for the Kent OHT, there's a few different roles that have come into it and from different places. It was certainly not a competitive atmosphere at all. It was a question of who had resources that could actually come to the table. So Chatham Health Alliance, I guess we have the good fortune of having a project management office, and really our lead, who's our interim vice president right now, who is also our director of strategy and performance management, I would say is the lead of that particular grouping. We have some of the resources from the LIN that have come in terms of project manager, and then some of the other work streams. So we really have, I'd say, a dedicated project manager, 1 to 2 days a week, and then some of the work streams have some other dedicated resources. The clerical support to the project management office has been seconded in there. We have the epidemiologist a portion of time from public health, and we also have some other resources from public health to come in there and help support that grouping.
Fantastic. Very helpful, Laurie. Matt, over to you.
Yeah, very similar situation for us here in Western Ontario Health. So we, in terms of our secretariat, we have a director, we have a system admin, we have an ethicist, we have a patient engagement specialist, clinical engagement lead, digital clinical engagement lead, population health lead, communication specialist, digital connectivity strategist, and a quality and performance design. So that gives you the sense of the roles. All of those roles are being filled by in-kind offerings from our partners.
Fantastic. How interesting with the ethicist among some of those other roles. That's great. Thanks, Matt. Heather, over to you with a question about, I think it was regional CBT resources.
Hi, yes. A couple people texted me directly too on this. So just to clarify, right now there's 4 specialty focused hospitals, and in the region surrounding those hospitals are where the services are currently available. Each region has its own service model, so sometimes it is hospital staff delivering the care in different community contexts, and sometimes it's staff of the primary care and community care organizations themselves delivering it. So it's a mix right now. The 4 areas are Ottawa and region. There is, kind of central downtown Toronto through CAMH. Ottawa is with the Royal Ottawa Hospital and their partners. There's east of Toronto, so a big swath of kind of Whitby all the way out to Peterborough, et cetera, and that's through Ontario Shores and their partners. And North Simcoe Muskoka, which is through Waypoint and their partners. So right now it's only those 4 locations, but there have been quite a few discussions and planning regarding what this would look like across the province. There has not been government approval yet, but that's where the conversation is happening right now.
Very helpful. Heather, thanks. Paul, thoughts from your side about whether you see there being particular challenges in having a municipal government at the table?
So long term, I don't think there's any bigger challenges, and in fact, I think it's going to work out really well. The more you can embrace local government as part of these, for the simple factor that health and local government has sometimes had a very wide gulf, and yet these are local issues that are affecting constituents of your local politicians. And so I think long term, having more of a sense and an understanding of how health systems are working and how services are trying to better connect with folks, it's less frustrating for a local politician. But that's later on as we get down. The challenge we do have now is when we talk about accountability agreements and we talk about governance structures, and yet we're in a vacuum. We had this experience when we took our update this month to our council. The governance hawks on our council were saying, well, what does this mean? And a lot of our answers were, well, we're not sure yet. We're being asked to look at governance, and there isn't a format for governance that we all have to follow. And of course, that creates a little bit of anxiety about, never would a local government want to usurp any of its responsibility. But the reality is most of human services are covered under provincial legislation. The exception to that would be things like transit or things like recreation that has a much more of a local control. So I think in the short term, we're going to find out that it's going to be very interesting on 2 fronts. One is without really strong approaches by the provincial government of how to do this, we're left with sometimes we don't know answers, which cause our local politicians, at least in this area, to sometimes furrow their brow a little bit. And there will be some concern about, usurping local control. But I do think in the long term, this is what they hear from constituents. They're constantly having to broker conversations with health organizations or the province itself. And as the population ages, it's going to even become more acute. So I actually believe, and we've witnessed as we've been very transparent with our local government about what we're doing and why we're doing it, that we have found the only pushback has been around, well, what do you mean there isn't a template for governance and you're creating this yourself? That's really been the only moment of, as I say, a little furrowed brow, but not enough for anybody to suggest this isn't a great way of working forward. And they really like the fact that this is even more local than the local health integration networks of the past.
Fantastic. Paul, thank you very much. We've had another question come in about resourcing these positions, but I think we've heard from Lori, Matt, Kyle about some of the innovative approaches folks are using, and I'm very sensitive to the fact that we're 2 minutes after the scheduled end. So if it's okay, I'm going to bring it to a close. Just first, thank you very, very much to Lori, Matt, Heather, Paul, and Kyle. We're very, very grateful to you. We learned a lot from you from having heard you speak before, often at our regional sessions. So we're grateful for you making time, especially on such short notice. We have 2 sessions coming up where we've already locked in on the topics. So I already mentioned population health management by Ontario Health Teams. As those of you who've been at regional sessions have heard me say, this is in a way the biggest departure from where we are in Ontario to where we can be. So Rob Reed will be leading that on September 3rd. And on September 9th, we'll be talking about how OHTs can approach their work with an attributed population. So by that time, teams will have all had their one-on-one conversations with the focal points at the Ministry of Health that are helping them understand the data that has been sent to them, including the maps with their attributed population. And we're going to be talking very pragmatically about how to make the most of what you now know about your attributed population at that session on September 9th. So just a reminder that you can register for these upcoming ones if you haven't already registered for the full set of them, and the recordings will be posted on the website shortly. So with that, we will wrap up. Thank you very much for joining us, and we hope to see you on Tuesday, September 3rd, when Rob Reed will be leading the session. Thanks. Bye-bye.